welcome. I am so excited to see you all today, and we're super excited to have our first grand round session. So thank you. Thank you all so much. So it is my pleasure to introduce our speaker for today, Dr. Ditchek, and he is the clerkship director at Memorial Healthcare System in South Florida, and he's a faculty member at OCOM. So we are super excited, and Dr. Ditchek is going to give us a sneak preview into how to read a trauma CT scan when minutes count. So we're super excited. A couple of housekeeping items. If you need to speak, ask a question. Dr. Ditchek will be, just kind of reading the room, but there will be a Q&A session. But if you need to speak, please announce your name and hit your microphone. Okay, if you forget, I will have to run back there and bring you the microphone. So remember to kind of hit your speaker. So people on Zoom, we have people who's joined virtually, and they will not be able to hear you unless you speak directly into your microphone. Okay, so let's welcome Dr. Ditchek. Thank you.
Thank you. Good afternoon. It's a great turnout. I took my first bright line today. It was awesome. It was great. I haven't had 3 hours to myself like that and got a lot of work done. It's really something. Last year I was the first guest speaker, so for OCOM in history, and so it's great to be back. Dr. Hasty and I can't believe it's really been over 20 years that we've been working together. Back in the Nova Southeastern days, and early in his career, where he was honestly a rising rock star, and I was giving just one lecture in one of his system courses in the second year, and we hit it off, and he said, the students need to know about radiology, and we gotta put something in there early in the curriculum. And so together we developed an M1 course for radiology there, and it was a really big hit. We were happy to put on quite a show. Then he moved on to bigger and better things, and I still give the course. Now I give his half of the lectures, which I'm happy to do, and it's really been very well received. And then his career took him on eventually to Idaho, and I got a call asking me can I come out and give a guest lecture in Idaho, which is a little further than Davie. And he said something about fly fishing. He said, "Come out here, I'll get you fly fishing," and I love fishing, but I thought he said ice fishing, and my Florida blood wasn't having it. So, but luckily he's back in the Sunshine State, and he asked me to come up to Orlando. And like I said, last year it was so exciting to be here for that beginning. I said, I got to get back there, and I've just been telling everybody I know about this place. Just exciting to watch it grow. It's just an amazing institution. CT of trauma, it's an exciting topic. I mean, for the medical students, you all came here to learn how to save lives. And if you really want to make an impact, you want to save a life before you graduate on a clinical rotation as a third year, fourth year student, I can teach you how to do that. In the next 40 minutes or so, if you pay attention and you practice these skills between now and then, one person in this room at least will save someone's life by making a critical finding on one of these CT scans and expediting the care of that patient. So it's real. It's very real. And I can tell you, I work in a level 1 trauma center. My fellowship up north was also in a level 1 trauma center. There's something very exciting about trauma. It's different every time. It's one of my favorite types of scans to read. But from the patient standpoint, remember that a trauma patient started the day as a regular day. It's not a sick person. And all of a sudden their life changes in an instant. And they're looking for someone like me or someone like you to step up really quickly and make a diagnosis and save them. And the minutes really count. And a lot of it is about the imaging and then what happens next. So we'll get into it. So this is how it goes down. They bring in the trauma patient and the ambulance and hit the door at the ER. And usually they'll try and get them into one of the trauma bay resuscitation rooms. But I'm not going to show you that because they're not there very long. They may go straight to CT. And we have a CT scanner in our trauma center that's essentially on the way to the trauma bay or right next door. So sometimes they get them in there right away. And that's what it looks like from the console room, the CT control room. You can see the patient through the glasses in the scanner. And there's two people there looking at the images, and neither one of them is a radiologist. So that's not where I'm sitting. I could be anywhere in the hospital. It could be at another facility with teleradiology. It could be anywhere. Those two people are probably the CT technologist who's performing the study and a clinician, maybe you, a third-year student, a fourth-year student, intern, a resident, a trauma attending, who's escorted that patient to the CT scanner. And depending on the acuity of that patient and the level of monitoring, there may be a whole team of people in there with the trauma patient. But that's the step I'm going to talk about today. Eventually, and hopefully within a few minutes, those images are then transferred from the scanner to the actual, what we call the PACS system, PACS, where the radiologist is going to read it and get those images as quickly as we can to a very knowledgeable and handsome radiologist to do the next step. But I'm going to concentrate on this step right here because sooner than later, you are here. You're a third-year student, a fourth-year student. It's going to be you in that room, and I can teach you how to help from there, right? That's what I want you to do. And the reality of how this plays out is that from that CT scanner, whatever comes out on those images and the proper interpretation is going to determine what happens next in a very real way. And in the golden hour of trauma, so to speak, where every minute and second counts, it would be great if we could make some decisions right then and there in the scanner and get that patient to the OR if need be, straight to the OR, right? It takes time to pack up a trauma patient with the monitoring and the IV pole on the personnel and get them back to the trauma bay, only to find out that there's a CT finding that requires emergent surgery and pack them back up and go to the OR, right? So that can happen. Imagine if somebody in the CT scanner decides, well, we're seeing something here that would require surgery. And of course, in my practice, 24/7, we're available. I'm going to read that study in a few minutes anyway, and you can call me for help. But again, it might take some time, for the images to cross over. The technologist is busy, and the reality of a busy ER, there might be a delay, and that's where you can come in. Now, the patient might have some bleeding or something else that will be amenable to interventional radiology. One of my amazing partners goes in there and stops that bleeding from the inside out, so to speak, with a minimally invasive procedure. That's fine. That decision can also be made and expedite the care. The patient's bleeding either way. Or maybe there's nothing really on the scan that indicates an emergent intervention right then and there, and we can take a deep breath, bring the patient back to the trauma bay for a conservative management and further resuscitation. That would be great if we can expedite from the CT to where that patient needs to go. So what do these scans actually look like briefly? You have your trauma patient here, and we're going to scan them. CT of the brain, CT of the neck, the cervical spine. Then we're going to inject contrast, and we're going to do a CT of the chest, abdomen, and pelvis. And from that, we can reconstruct the entire thoracolumbar spine in a dedicated study. We can make 3D images of anything there. And there's a bunch of pictures that come out really within seconds. That scan, the chest, abdomen, and pelvis, how long does it take for that patient to go through the donut of a CT? And it's really a big X-ray machine, essentially, and it's spinning in there, and the patient's moving through chest, abdomen, pelvis. How long do you think those images take to acquire? 4 minutes, 30 seconds. My fast scanner now, chest, abdomen, pelvis, 1 to 2 seconds. It's actually frightening to watch that patient slide through the scanner. The first time the new scanner came, I thought the patient was going to slide through the donut and hit the wall, but the scanner's fast, right? So we're cranking out these images, and that's the trauma protocol. And essentially, this is what we wind up with. And I always like to say, if you see an ambulance going by and the lights are on, the patient's getting an X-ray, at least. If the siren is on, the patient's getting a CT. And if the patient's on a backboard, on a trauma board in there, they're getting this. 7 CTs and probably a CT of anything else that's hurt or lacerated. And that's just, the way it goes. And that makes counted on the average size patient of over 1,000 images, right? Now, don't forget, the trauma team is right there, and they're ready to go. This is the speed at what trauma surgeons like to move. And there's 1,000 pictures here, and somebody, including you, standing at the scanner, might have to, look at this, right? And they don't want to be standing like this, which I have seen, and that's an uncomfortable position while they're waiting for me to say something smart and see where to go next, right? So that's not how you want your trauma team looking. And they will inevitably say, can you take a quick look at this? Now, if they haven't taught you this yet in school, somebody's teaching every medical student in the country this expression. This is how you're meant to interrupt the radiologist, right? So if your patient that you're seeing in your office or whatever it is more important than the one I'm reading, and you want to be apologetic, you call me up and say, can you take a quick look at this, right? And the question is, can you take a quick look at 1,000 images? And the answer is, I have found over the years, yes, and I'm going to show you how to do that. But how do I know that? Well, it turns out this you are here, when I was a resident and a fellow, I was there, right? So that's where I was on the front line as a radiology resident. I am literally putting the patient in the scanner with the trauma residents. hooking up the IV, flushing it, getting the contrast injected, working with the CT technology on the protocols. And it's 1 a.m. and there is no attending, right, anywhere. And this trauma team is hovering over me, and I'm waiting for a decision from me. And there's not an attending for miles, at least when I was training. And I might call a grade 4 splenic laceration. They're going to take the spleen out now. And then in the morning, maybe my radiology attending doesn't agree, but the spleen has now been in a bucket for 6 hours, so it doesn't matter. So that's where I was. So I had to come up with a way to take a quick look at this while the trauma team is breathing down my neck and the patient is borderline unstable. And where are we going now from the scanner, right? So that's what I'm going to show you. And this algorithm that I came up with, this little approach, you can do it. You can learn to do it because there's not that many things that you actually have to look for in this setting, right? If you miss that incidental adrenal nodule, don't worry about it. We'll get it later. But in terms of where are we going now with this patient, there's not that much that you need to know. What do you need to look for? And I'm going to give you some tips on where and how to do it. There's only 2 things, and then you're going to see why. You got to find fluid. If there's any fluid anywhere that has to catch your eye, and I'll show you what it looks like. And in particular, the fluid we're looking for is blood. So I'm going to turn that red and put a little star on it because there's a couple of tricks you need to know, or air. If you find fluid or you find air, that's where the action is. If you don't find either of those, there are very few significant injuries that are going to require an intervention right now, and you're probably safe to go back to the trauma bay and wait for the final reading for the radiologist. So you came here for trauma, for the blood and guts, so let's get into some cases here. And unfortunately, in our area, we have our stretch of I-95, and it's carnage on a daily basis. And if you work, I'm actually the radiology liaison to the trauma center, so I'm in on every one of their peer review and M&M committee meetings. So I get to see every really bad trauma outcome in our North Broward County. And so there's too many of them, but we can learn from these cases. So a patient comes in that kind of an accident, blunt trauma, MVC, and POCUS, right? Nowadays, people are doing scans in the ER on the front line. And the initial version of POCUS really was fast, right? That was the quick scan that the ER or the trauma team can do to look for fluid, right? Because we shouldn't have any fluid. Our bodies are actually dry. You'll be amazed when you start scrubbing in on surgeries, there's not a lot of fluid in there. What separates the organs in our body is fat, right? It's adipose tissue. That's what's in the abdomen, the retroperitoneum, the chest, everywhere. It's not actually that wet. There's no collections of fluid in there. And we're going to rely on that because if we find fluid in the trauma setting, then it may be blood, and we're going to get into that. So in this case, they did a fast ultrasound on that patient, and it was grossly positive. There was fluid everywhere. And there they go, right? Let's go, let's go. You can almost hear them saying, let's go. They're going to the OR with that patient because of the fast trauma. But the patient was borderline stable enough, and they went to CT. Why did they do a CT? All together now, because they always do a CT. Did I say that out loud? In any event, they get the CT scan, and it confirms that the patient is a belly filled with fluid. You can see the fluid here and posteriorly, and so much fluid in there, in fact, the bowel is all floating in it, right? And I told you there shouldn't be any fluid. So let's go to the OR, right? It confirms the CT, the ultrasound, let's go. Actually, I had to kind of get in front of them, and I said 3 words. It's not blood. Don't go to the OR, right? And you can go back to the trauma bay, and there's nothing here to do. So the question is, how did I know? So I think these kind of interesting cases are a fun way to introduce some basic CT concepts that you can use to read any CT down the line. So here we go. CT is an X-ray. It's a cross-sectional X-ray. Instead of the beam just coming through like a sheet, it's coming through from 360 degrees. But the same shades of gray that you probably already know, bone is white and air is black and everything in between, is true on CT. Dr. Hounsfield, one of the inventors of CT, said, we have a digital modality now, right? So we don't have to have these like qualitative densities. Every pixel on the image is assigned a shade of gray. So let's just make an arbitrary scale of this grayscale on CT from black to white. And we'll just assign arbitrary numbers of densities to this so that we can kind of talk in more quantitative terms. And they decided, let water be set to 0. So if you took a glass of water and put it in the CT scanner and scanned it, which you could do, and then you got an image of that, you could draw a region of interest within that image of the water, and the software will return the average density of the pixels that you're looking at in Hounsfield units, and that should be 0. And in fact, they have things like that that they use to calibrate the scanners and check them, different densities, different substances. Now, it's an X-ray beam, right? So different substances block that X-ray beam to different degrees. Anything that's denser to the X-ray beam that blocks it more is going to be brighter, whiter, denser. Those are all synonyms on X-ray, and be in the positive range on the scale. So liver, muscle, right? That's denser than water to the X-ray beam. You get into the 50 Hounsfield units, something like that. Of course, calcium we know is white. You think of an abdominal X-ray, right? The bones compared to the liver, for example, even whiter. Now think of a patient with a pacemaker. What does that metallic device or a bullet look like? White, right? So that's this end of the Hounsfield scale. And anything that lets the X-ray beam through even more, it's less dense to the beam and exposes the detector, or what used to be the film, more, will be darker or lucent, right? Less dense than water, and that you start to get into the negative range. So fat kind of floats on water. It's a little less dense, so to speak. So that's going to be in the -50, -100, all the way out to the pure blackness of air, which is -1,000, -1,500, something like that. I'm going to give you, we're doing trauma. Let's put on a couple of more points on here. If you scanned a tube of blood, which is fluid, but it's not water, it's denser, it's about 40, right? And what's in the blood that makes the average density a little bit more? It's something from the periodic table that's a metal, right? Iron. So iron is dense, right? It's not pure iron, but there's metal in blood and it raises the average density. Oh, so now I can start to distinguish blood, let's say, from simple fluid, right? And that we're going to get back to that case. One more point on this line for now. Hematoma. When blood clots, it becomes even denser to the X-ray beam and you start to get these densities. And again, you can measure this. You can learn. You should all learn to measure these regions of interest on a CT scanner. And by the way, when your friends and family start bringing you discs with their scans on it, if they haven't started already, every disc they bring you from their imaging center has a mini PACS viewer software kind of embedded on it. And it has all of these tools. You can measure distances, but you can measure densities, and you should learn how to do it. Okay, come back to this patient. You guys forgot we had a patient on the table. So how did I know? I'll just draw a region of interest with the software, and instantly it tells me what the average density of those pixels are in Hounsfield units. In this case, it was 5. 5's close to 0. It's really watery, serous fluid. It's not 40. It's not 60. And that's how I knew this lady's not bleeding. She has a belly full of ascites. Right. And then, she just came in bad shape. No one got a full history. I don't blame them. They had, ABCs and all the trauma stuff first. But as the dust settled and, we had more chance, they found out that she had a history of ovarian cancer. And it turns out that patients with cancer are allowed to get into car accidents. Right. So she had ascites for a completely different reason. And the last thing she needed, she has enough trouble right now, is a laparotomy. Right. So if she go to the OR, be a little bit unnecessary and embarrassing when 2 liters of ascites spills out when they open up and there's no blood. But the CT can tell you that, right? Truthfully, the fast ultrasound can tell you that too, because pure fluid on ultrasound is what color? What shade of gray? Anechoic, pure blackness, right? But ultrasound of blood has some low-level internal echoes because there's blood cells in it. So you should practice when you're doing POCUS, deciding whether the fluid is truly simple fluid or complex fluid, blood, pus, or something else, because obviously the clinical implications here, she could have gone to the OR wrongly based on the fast if someone didn't say, hey, wait, this fluid looks really simple. Does she really have blood, hemoperitoneum? So you have to make that distinction. Next case. Starts like that, ends like that. Was a kid, and he winds up on the handlebars. Here's the CT through the abdomen, and that crescent between the liver and the edge of the peritoneum, that's fluid of some sort. I told you the body is dry, so there shouldn't be any fluid. There's fluid there. There's fluid in the left upper quadrant. Well, what kind of fluid is it? Let's start taking measurements. You can draw a region of interest, an ROI, anywhere you want. That one was 40. That's blood, period. And that one was 60. That's even denser. So there's blood and clot. Draws my attention more to the left side than the right, frankly, because it's a little denser there. And if you didn't see it originally, now your eye is drawn to the left upper quadrant, and the culprit is a big laceration in the spleen. But even a more subtle laceration in the spleen should have been detected because you see there is hemoperitoneum, densest on that side. There shouldn't have been any fluid in the first place. So that's the diagnosis in this case. Now, that's what we're looking for. And the question is where and how do you look for this fluid? So think about the peritoneum, and you can see that it's outlined here in the whole pink cavity there. but it's all about gravity, really. And radiology is a lot about positioning of the patient and where do we expect things to be. So the gravity dependent portion of any structure in these patients is going to be posteriorly, because the patients have been on their back since they got hit by the car and scooped up on the backboard. And even in CT, they are supine, right? So I'm going to turn this like this. And now looking at the peritoneum from that point of view, where is the most gravity dependent portion of the peritoneum? Always, and just by anatomy, it's there. It's in the posterior lower pelvis, sometimes called the cul-de-sac, right? So the anatomy is going to come into play. And when I read a trauma CT, I actually scroll with my mouse wheel as fast as I can down to the lower pelvis. If that's dry, then there's probably nothing else going on. Any blood, even from the spleen, the liver, is going to drip down and get down into the lower pelvis. And this is that cut. You can see the bone there. I'm at the level of the acetabulum and the hip joints. And right there should be dry. That's all fluid. How dense is it? It's dense. I can measure it. I'm going to get 40, 50, 60, but I'm going to show you another way to even more specifically confirm that this is blood. Can you see that there's actually different layers? There's different densities in there. It's not homogeneous. The more dependent you get posteriorly, it gets denser and denser. And that's a unique feature of blood as a fluid on CT. The blood cells will actually layer out posteriorly due to gravity. And we have a name for that in clinical medicine, but we don't really think of it this way anymore because the lab just spits it out and puts it in the chart. What's the term for that phenomenon? If I drew your blood and taped the test tube to the wall and we came back in an hour, it would all the red cells would have gone to the bottom. I can put it in a centrifuge and we'll do it in a few seconds. What's that phenomenon known as? We use it every day in clinical medicine. No, that's the rate at which it happens. But the actual phenomenon is the hematocrit. That's what we mean, right? The blood will layer out, and a centrifuge just makes it happen faster. And that free blood is not circulating anymore. It's just in the pelvis, will layer out just that way because the cells will sink to the bottom. So we call that the hematocrit effect, and it's specific to blood. So I know this isn't ascites, right? It's some sort of complex fluid, and typically it's going to be hemoperitoneum. Okay, next case. So yes, there's blood around. There's blood over the liver again. There's blood over the spleen. So we have a upper abdomen, peritoneum filled with blood. But what is going on there? If there's a density, a shade of gray that's just not supposed to be there, it has to catch your eye. And this time it is white, right? What is that white stuff coming out? And where is it coming from? It's actually, you can see it on this image, it's actually spurting out, so to speak, from the liver itself. So let's go back to the Hounsfield units. I got to give you one more point on here, and that is iodine, IV contrast, right? What's the density of iodine? I don't know. It's hundreds probably in the syringe. We use it because it's white on CT. When it gets into the bloodstream, when I inject it, it'll mix with the blood and dilute a little bit, but I'm doing it in such a way to blast that bloodstream with that iodine and turn the blood white, so to speak. So first pass iodine going through the bloodstream is hundreds of Hounsfield units. It will be white, and that's what we're seeing here. You have to picture that that's white iodine squirting out of a lacerated artery. You see this image, you need to be thinking of that picture. That's literally what's happening now, and that's been happening since the guy got hit by the bus, right? It's not contrast, there's blood coming out, and it's been coming out all along at arterial pressure. So first of all, get him out of my CT scanner because that's the worst place he can be. And let's get going on some sort of, definitive surgical or interventional treatment, right? So active extravasation, extra meaning outside, vasa meaning vessel. You got to pick up on that. Someone has to pick this up. If you're not sure, look at it, call me. Hey, I think there's active extrav. What do you think? We got to move on this. And again, my fear is that those images come to me a little bit later because there's a brain attack on the next patient, and they got to scan that first, and then the CT tech gets me the images for both, and this patient's bleeding another few minutes, and all I want to know is, does anybody know that this is going on by the time I got the images, right? I look at the timestamp on the images, and I look at my watch, and that's why I'm here, because I got to close that gap so you pick it up and make a phone call. That's how you're going to save a life. Yeah, this one we got to go right now. The patient is bleeding out, exsanguinating into their abdominal cavity. You can put your whole blood volume in there, and that's how the patient will crash. All right, have you guys seen, what do you do with this patient? Have you seen this one? No, don't. You ignore this guy. What is this? It's an internet prank, right? Around the holidays, it's supposed to look like someone was stringing up their lights. I just don't want you to fall for it because they're on the doorbell camera. they're videotaping you, and you're going to be, running to save this guy, and the rest of your life you'll be on the wrong side of that YouTube video. But having said that, at a level 1 trauma center in South Florida, we get people falling off their roofs this time of year, hopefully not this year, because of storms. You have them here too, come through after a tropical storm, a hurricane. We have leaks, and people go up for the first time in their lives to put up these blue tarps, and it's wet and it's slanted, and they just don't know. And this guy fell. He fell off the front of the roof and actually landed on his back, but he was draped over the banister backwards. So he obviously excruciating back pain, level 1 trauma. They brought him in, and this is his scan. He injured this organ, which we call the pancreas, right? Now, is the pancreas intraperitoneal or retroperitoneal? Mostly retroperitoneal. Now, retroperitoneal bleeds generally are less concerning because the retroperitoneum is a smaller, tight space, and generally, if the patient is bleeding, eventually it'll build up its own pressure and kind of tamponade itself. So they'll watch these patients, they go to the ICU, they may transfuse them, but generally the surgeons are not inclined to open up the retroperitoneum, and they'll just kind of watch them. And so if I say pancreatic injury, they'll just watch the patient, not interested in any kind of intervention at this point. But let's look at what really is happening here. You're supposed to look for that white contrast extravasation, and there it is. And it's bleeding anteriorly from the pancreas. And not only that, it's active extravasation, and it's starting to form a hematoma more anteriorly in the space between the stomach, behind the stomach and in front of the pancreas. M1, I don't know if you got the M2 anatomy, anybody? What's that space but behind the stomach and in front of the pancreas? Nope, not more says Pat. The lesser sac. The lesser sac. Now, the anatomists love to talk about recesses of the peritoneum. Remember all that stuff? You didn't think that was, important? So this is a recess of the peritoneum, which means when that lesser sac is full of blood, the blood is going to be able to leak out of there and start pouring into the rest of the peritoneum, not the retroperitoneum. This is a life-threatening hemorrhage. And how's it going to get out of there? Somebody, an anatomist. Yes, the foramen of Winslow. See me after class. No one ever gets that. The foramen of Winslow, which you thought was just some structure that Dr. Winslow wanted to name, and who cares? It's the only way in or out of the lesser sac. But the foramen of Winslow, the meaningless anatomy that you didn't want to learn, is going to kill this patient because it allows that blood to get out into the peritoneum. So this was a doctor-to-doctor call. I called the trauma attending. I'm like, look, I'm telling you it's a pancreatic bleed, but it's hemoperitoneum. It's not a retroperitoneal version of this. It's got to go to the OR. But not only that, what's satisfying for me as a radiologist on this case is when they go to the OR and they open up, what are they going to see? A belly full of blood. And they're going to start sucking it out as fast as they can. And where are they going to look first? The usual suspects, the spleen, then maybe the liver. Where's the last place they're going to look? Mobilizing the stomach and looking in the lesser sac on the front of the pancreas. But I told them, let that be the first place you look. Nothing else is bleeding. Mobilize the stomach, cauterize the front of the pancreas, and you're done. There's nothing else going on. The seconds count. This is an active hemorrhage. So that's the interest, for me as a trauma radiologist. Okay, so that's what you're looking for, right? Fluid. And then there's also air, right? And fluid, we're talking about blood, obviously. Now, our body is dry, and fortunately for this purpose, the body is also airless. It's actually, if you think about it, it's true. There is no air, not a molecule of gas in any of these cavities. None, not a single drop in CT. Now, the only air in our bodies is what we breathe in and out of our lungs, and what we swallow into the GI tract comes out the other end. That's it. So there's nothing, there are no, like I said, any foci of gas or air of any kind anywhere else. And that's very fortunate because it points us to pathology. And the other good news is that air is black on CT. It jumps out. If you know how to look for it, it jumps out. So here we go. So where are you going to look? Well, if you're looking for fluid on a supine patient posteriorly and gravity, where do you think you're going to look for the air? It's going to rise. So one scroll through on the mouse wheel every time for me is just looking for the air. And I'm looking anteriorly, right, for in that supine patient. So this is an easy one. All that black air in front of the liver is abnormal. That is massive pneumoperitoneum. It's true in the trauma, but again, I'm trying to give you skills that will extend to other patients. So that actually, this patient had a ruptured gastric ulcer, a perforated ulcer, and leaked out the air there. It's also a surgical emergency, right? Air in the abdomen indicates perforation of a hollow viscus of the GI tract, right? That's it. It's the only thing that could have caused this. So it's a surgical emergency, right? I like this one because if I put all these stars on, every one of those black areas on the image, you can see a little wall around it. That's intraluminal air that has been swallowed and it's working its way through the GI tract. It's totally normal. The rest of that is abnormal. So intraluminal, normal, extraluminal, surgical emergency, and you should account for every dot of air on the scan. Now, here is a tiny bubble of air that counts. Like that's abnormal. Maybe it perforated and stopped, but you got to check this patient out. Rebound, guarding, right? Physical findings. Now, what about how to look? On this one, there's air, there's free air. It's not so easy. You're looking anteriorly. Maybe it's there, maybe it's not. Switch the display setting, and you should ask the CT technologist to show you how to do this. We don't review a CT scan on only one setting. It's kind of like changing the brightness and contrast on your phones to make the images look a little different, and the grayscale gets portrayed. So there are what we call windows, these standard settings, abdominal window, bone windows, lung windows, to bring out different parts of the Hounsfield unit scale to more advantage than at one point. So to look at the lungs, you got to be at lung windows. Then you look at the bone windows, and you have to keep scrolling back and forth. So when I say 1,000 images, it's really 3,000 by at least to look at on different settings. This is a bone or a lung window, which makes air black, stays black, and everything else just a couple of shades or white or gray, meaning the air jumps out. So I scroll through one time, and you should do that on either bone or lung windows, make the air really black, and ignore everything else. And then you can account for every pixel that's black, and you decide whether it's intraluminal or not. Let's talk about chest injuries, blunt chest trauma. And the good news is we're almost done because everything I told you in the abdomen so far, those were abdominal cases, it's all the same. You shouldn't have fluid, blood, and you shouldn't have air in any of the spaces of the chest. The mediastinum, the pleural space, the pericardium, they're dry and they're airless also, right? So if you have blood, if you have air, then you got a problem. And if you don't, you probably don't have that, big of a trauma going on. CT scan of the chest, right? This is the so-called soft tissue or abdominal windows. So I get no detail in the lungs. The lungs should look black because they're air-filled. Look at the normal side and the right side, and the lung goes all the way out as expected to the edge of the chest, fully expanded. On this side, on the left side, this is the edge of the lung, which in anatomy we call there's two layers of the pleura, so 50-50. No, visceral pleura. The visceral pleura is the edge of the lung here. The parietal pleura, by definition, is out at the edge of the lung, and the pleural space, which they tell you in anatomy, is a potential space. I never knew what they meant by that as a first-year medical student, but now I do. It's a two-layered structure: visceral pleura, parietal pleura, and normally they're plastered together. It's potentially a space, but in the normal setting, it's not. Then it becomes separated by blood, air, pus, simple fluid. Now it's a real space, and now it's a real problem, right? So that's what we're dealing with. In this case, there's fluid in there. Patients laying on their back, as expected, the fluid sank to the posterior aspect of the pleural space. But what kind of fluid is it? Same principles, just take a Hounsfield unit measurement, 50, it's blood, right? What else? What other phenomenon is shown there in the pleural fluid? There's two layers. You have a hematocrit effect, right? Posteriorly is even more dense. It's showing you that's the blood, that's the red blood cells posteriorly, and the plasma is already layering on top. Okay, but let's say the patient is stable. Hemodynamically, they're okay. They bled into the pleural space, but they're holding their blood pressure. They're doing all right. You're not inclined to drain this right now, and you're gonna just take them to the ICU and keep an eye on them, right? Or move them it's really stable. Move them to the back of the ER, and in 6 hours, get another CBC, right? We could be good. You got to look at all these images on more than one setting, right? I told you on this image, there's no information on the lungs itself, the lungs themselves. So you got to switch to the lung windows. Now, again, look at the normal side. We have the texture of the lungs and the blood vessels running through them. And that lung is all the way expanded out to the edge of the chest, right? Where's the pleural space on the right? Normally, it's a potential space. It's here. Parietal and visceral pleura are all the way out. You don't even see it. What do we got going on here? There's pure black air, and there's a pneumothorax. This is the visceral pleura anteriorly. You couldn't appreciate it on the other window. This is a pretty big pneumothorax. This patient is going to buy a chest tube, right? So it's not the patient that you just want to ignore because they had maybe a small hemothorax. This is a hemothorax and a pneumothorax, and it's going to affect your management. You got to change window settings, learn how to do it, and look at each of these images on multiple display settings. All right, South Florida trauma. I brought this guy, I think, from the Upper Keys. So for tourists who they want to go scuba diving, but they don't want to spend the time or money on the lessons, and snorkeling is not cool enough, they have this, which is called snuba. Okay, good luck. So they go diving. It looks like a lot of fun. I don't know. To me, it's pretty terrifying. You go down 30 feet and you just have this little air hose to this floating compressor. But I'm in the boat fishing anyway, and these guys are just scaring all the fish. So here we go, 33-year-old guy, and he was diving. All of these are cases that came through our practice. And while he was down there, the air hose actually kinked and cut it off. So that's a bad feeling. So he quickly swam up. And as he did that, the hose released, and he got this huge blast of compressed air. And he comes up and he's complaining of neck pain and chest pain. So they take him into the trauma center. And here is a CT chest of this patient. And I'm displaying it on lung windows. Does he have a pneumothorax? No, both lungs are fully expanded all the way out to the edge. You don't see any pure black air in the pleural space at all. Does he have a pleural effusion or hemothorax? Nothing layering back here. What does he have? There's an abnormal density, which you now know to look for. Where's the abnormal density? A different color that shouldn't be there, a shade of gray. The space between the lungs is the mediastinum, right? What's in the mediastinum besides vessels, lymph nodes, esophagus? What separates the structures? Fat. There should be no air. We have pure air, blackness of air. This is air in the trachea. That's fine. This is air in the esophagus. You swallowed some air. That's fine. All the rest of this air tracking around in there is pneumomediastinum. Also abnormal, not life-threatening, but painful. It's probably self-limiting. There's not much to do. We're going to, supportive care, pain management, and so on, and it'll reabsorb. But we got to keep an eye on him. He ruptured a small bronchus probably, and that air from the baro trauma, and then that air tracked back into the mediastinum, and this is how he presents. So again, these densities you got to look for, but if you find air, then you have a problem. So you can learn to do this. You got to practice, right? You can learn to do this, but I want you to be kind of ahead of me on this. This is one where I need your help. Dr. Hasty knows from my lectures at Nova, 90% of the time, I'm teaching what I call imaging utilization, right? I just see clinicians that just across the country haven't been trained in what's the right study for this clinical scenario, right? So most of the time, you're not going to be faced with a situation where you have to interpret high-end imaging on your own. And the real challenge for you is to find ways to learn what is the one best test for that clinical scenario. And in my opinion, because I can't resist, history and physical, differential diagnosis, working diagnosis, and now that last link is one best test. What is the modality, the body part, and what we call the protocol? You want contrast, no contrast. That's a lecture for another time, but that's the main skill set for non-radiologists, for the clinicians. And it's not really being covered nationwide, and I'm not sure why that is. So there's tons of confusion, but there's a few instances where I need you to look at the images, right? You put a line in a patient, hopefully you get to put in central lines, NG tubes, all that stuff. You check the x-ray. You know it was done way before me, right? You're in the trauma bay, you're in the trauma CT scanner. You know this is happening. I won't know till it's complete, and it's going to be put on a list of, frankly, several other CT scans that are just as stat, and all they all say to me is a name, a medical record number, and one word, which is pain. That's the history I get. I don't have a way to triage this, unfortunately, because there's a lack of understanding that I would do the triage if you gave me some clinical history. The point is, you're ahead of me on this. You have a chance to jump in and save this patient and expedite the care. And I just don't want to read an image that's delayed and nobody found that big pneumo, right? Or that active bleeding. So now you know what to look for, fluid. You got to use your density measurements, learn the Hounsfield scale. It actually is, it's very intuitive because it's CT is X-ray. But come back and we do MRI, whole different shades of gray and different orders. But we all know the X-ray densities, right? So use them. It's just that now you actually have the numbers. So you can quantitatively say, no, this is simple fluid, or yes, this is blood, this is clot, or there's blood squirting out with contrast, actively bleeding out this patient, right? And then there's air, right? And the air is black, it's easy. Where do you look? It's all about gravity. The patient is always supine in the scanner. They've been supine since the trauma, right, on the backboard. So air rises, fluid sinks, and blood has that other phenomenon besides being dense that it actually will layer out. So you can see it. You can learn to detect these things. Learn how to manipulate the console, the CT scanner, the imaging measurement tools, right? And they're available at nursing station. If you're in a rush and they're getting out of the trauma bay, go back to the nursing station, pull up the CT anywhere, and these tools are available. It's not as fancy as what I might have on my full 4 monitors, but you can all take an ROI measurement. right? And don't forget, you can't just scroll through it once. Scroll through it once, change the window. It's one keystroke, right? They're all kind of shortcuts, and get familiar with that. And the last part, which is how I teach it, is look between the organs. In the heat of the battle, you don't have a chance to run your checklist. I can teach you a checklist: liver, spleen, pancreas, kidneys, adrenal glands. I can teach it to you. That's not how you do it in the heat of the battle. That's for me after to be compulsive and comprehensive about the whole thing. But if you need to know if something's going on, the action is going to be that the air or the blood, it starts to track around and it's between the organs. And that's all you need to know. And generally, it's going to be centered on the culprit, even in a non-traumatic sense. So if you learn to find edema, which is simple fluid, and you just scroll through one time looking for edema, I can show you that in a different lecture, you find edema in the right lower quadrant, it'll be centered on the appendix and you have your diagnosis. Or it's centered on the ascending colon and you have diverticulitis, right? And you look for the diverticulum. So the action is between the organs, because normally what should be there is fat, pristine fat, which has a density of negative Hounsfield units, and there shouldn't be anything brighter like blood, and there shouldn't be anything black like air. And really, the vast majority of traumatic and non-traumatic emergencies are going to cause some sort of fluid, blood, edema, or air to surround them, and they're otherwise not going to see those densities. So M1, M2, but M3, M4, this is you. You're going to be there. It's exciting. It's interesting, but you don't have to be a spectator. Like, learn these skills and then point something out to the resident, to the radiologist, to anybody. You say, I think this is bleeding. I think there's air here. You can do it. And if you move that patient up 10, 15, 20 minutes while they're actively bleeding, you did it. You saved them. That's it. And it's a skill set. Again, it's one of those carve outs where I want you to understand a little bit about the interpretation. It's going to pay off. And then you won't have to leave them waiting, right? So that was my motivation to learn this, because the trauma team, they're hovering over, literally, I'm sitting at the console and they're looking at me, where do we go? Where do we go? And they look like that, actually. And I just had to figure out a way to, can you take a quick look at this? Yes, you can do it. And then after, when the dust settles, we'll find the subtle stuff that's not so emergent. So hopefully that's a helpful overview. It's I think for me, a fun way to introduce CT to you in a kind of an interpretation level that everybody can learn to master. And trauma, again, is different every time, but there's some principles here that are going to just really be constant for you and help the patient, which is what we're really doing. So I'm going to stop there. I appreciate the attendance and the attention. It's really great to be back. I'm really happy to be here, but we have time for a few questions. Okay. That's it. All right, they're all ready to save life. We'll do it. Who's on tonight? Yes, sir.
Yes, my name is Ashan Kashif. I'm an M2, and I just wanted to ask, what are your some advice you have, to stand out as a DO, like in an audition rotation for radiology, or like even applying for a radiology specialty?
Okay, so for a Zoom, the question is about how to shine on audition or rotation. What can you do to stand out for if you're thinking of radiology and apply yourself? So first of all, don't underestimate the power of an audition rotation itself. Research is great. Anything you can get on your CV that shows you're interested in any given field, that you use your spare time constructively to do certain things, that's fantastic. And I will say one caveat: I don't have a radiology residency, so I'm not selecting residents, but you'd be surprised how far it goes if you do an audition rotation at a place that does have a residency and they really get to know and like you. Because I don't know where you went to undergrad, but for many of you, you probably were accepted into a freshman class in college of several thousand people, and you were interviewed by someone who was never going to see you again. It was kind of a screening thing more than anything else. And even here at the medical school level, classes on the order of 60, 80, 100, 200 people. And you may or may not see that interviewer again. At the next level, you're going to a radiology residency of 4, 6, 10 people. You're no longer a student in that department. You're actually a junior colleague. And the attendings are going to be depending on you to work side by side with them, to be helpful, to be pleasant, to cover their practice at night, and all of these things that they would expect of a colleague. And so it's a different level now. They really need to get to know you. So my advice is to find places that your advisors here will tell you that based on your initial performance here, what could you reach for? What will be a good school that you have a solid shot at? And if they have a residency there, that's what I mean, go there and be present, be in the discussions. I'll give you a little trick that if you get 2 to 4 weeks, you have time for this. Early on, you might find an interesting case that comes up, and even you see the attendings like, wow, I wonder what this is actually going to turn out to be. A lot of people don't follow up. They just dictate the case and it goes into space. I actually drag and drop those cases into a follow-up folder on PACS. That's how I build my teaching file, because I get the path back soon, or the op note. Well, if you have access as a student to their system, follow that case up. If it really seems like everybody was interested or confused about it, and if you're hopefully in the next few days, it goes to the OR, you get the path back, circle back to that attendant. Do you remember that, interesting complex cystic renal mass? They took it out last week and it comes back as clear cell carcinoma. How do you know, right? Oh, I looked it up. Nobody does that. So that's a good thing. Just so they see that you're interested in the follow-up, you're trying to learn from every case, even if it takes a few days. Anything you can do like that to say that this is going to be the kind of resident that we want to have in the department, and research and everything else. But I would rather you do 2 or 3 audition rotations in places that you have a shot at and be the kind of resident. I had a student from Nova, and he did that, and he was so kind of like helpful. He was an IT guy, and when things weren't working, he asked, "You want me to try, help?" The residents got him into the residency, right? They said, we want this person. We want to work with him as one of our junior residents. And they would have to wait 2 years, right? Because we do PGY1 something else. But they told the attendings, you got to take them. And all things being equal, I think the residencies will take someone they know and like, all things being over just another envelope, another folder of an applicant.
Thank you.
Yeah. All right, so someone got at 4 o'clock in the morning, gonna be with me all night. We have a radiology elective. It's a 2-week elective, and I always tell the students I don't have you. It's an elective, so I don't have you working overnight, but I could and I probably should, because you'd just be amazed at my CT scanners. I don't even know how many we have. We're going full blast through the night. We just can't get caught up. And MRI is now in-house techs all night. Used to call a tech in to do an MRI. Those days are over. CT, ultrasound, MRI, around the clock, full blast. My partners and I, whoever's on, reading through the night. There's no call in radiology anymore. You're not on call. It's a shift. It's as busy as it is at 3 a.m. as it is at 3 p.m. It's really something, in terms of the volume. We're putting up numbers I never thought we'd see. And unfortunately, and I work in a good healthcare system with sophisticated clinicians, it's just nationwide, like I said, these gaps. You're going to have to kind of fill it in and understand how to utilize this. My prediction is it's going to break. We can't keep adding scanners. And before you're done with your training, the rules are going to have to change. And they're going to watch you so that to see if you're an ER physician, let's say, and in your ER, where do you fit in on the utilization rates? For every patient, every 100 patients that you see in the same population, another physician in your group, how many CTs are you ordering? How many ultrasounds are you ordering? And do you have, if you're an overutilizer, do you have metrics to show that you're doing a better job? You get fewer bounce backs or something. Otherwise, you're going to have to justify it, because patients are waiting longer and longer nationwide. There are radiology practices. I have friends that they're not caught up. They can't get to these patients and scan them, and they can't read them for not hours, days. Can you imagine? And the patients have a portal now. They're waiting for that. And we've all had loved ones that had a scan of some sort, and that at that point the care stops. Right? They're waiting for the result of whatever that scan is, and they're refreshing on the portal. Right? And that's what they're waiting for. But the system is actually starting to break for inpatients and outpatients and ER patients, which all have their own time frames. In many parts of the country, it's happening. So I think they're going to have to come back to radiology education for this and add that in, and some kind of metrics and a little bit of old school, physical exam and clinical history. It's funny for the radiologist to be telling you to sharpen your clinical skills, but you're going to have to do it. You won't be allowed to put the patient in the scanner first, which is what goes on in a lot of places. Not to mention that I scan the abdomen and pelvis 15 different ways. I have built-in protocols that are evidence-based, and they're for particular clinical scenarios. So you should be telling me whether this patient has painless jaundice and you think they have a pancreatic cancer, or do you think this patient has a pulsatile abdominal mass and they have an aneurysm? Because I have 2 different ways to scan it. Yes, you can order it as CT abdomen and pelvis, but how thin am I slicing it? am I giving contrast? What rate, what volume, all kinds of technical parameters that you don't need to know, but you need to know that a good imaging center is going to provide that and have a better sensitivity for your working diagnosis if you match the indication with our protocol, right? But it's probably the best kept secret in clinical medicine, you know, and that there's different ways to do this and that we can actually optimize the scan. And I can't tell you that every imaging center is doing that or interested in it, but the good ones are, the academic ones are, us at tertiary care, we're doing that. And so you need to learn how to harness that, you know? Yes.
Hi. I was wondering, my name's Joey, by the way. I was wondering, do you know any good resources to look at imaging with like pathology, just to compare, like we have like a ton of normal imaging, right? I'm just wondering if you know a good source for that, especially for when it comes to like clinicals, you could know exactly stuff that will pertain to where you're going.
I thought you'd never ask. Can I show them? Okay, so I was going to show you this after for just the students. There is a shocking lack of resources, and this is coming to me from my medical students for decades. I don't know why. You know, has everybody heard of Pathoma? Right, every student in the country, you know, uses that to augment their pathology knowledge, but there's nothing. Tell me if there is. But I've asked hundreds of students because we have people rotating through our department from different medical schools. Also, I have 50 new interns every year in my hospitals from other residencies, and I give them radiology boot camp. There's nothing out there. So I have been asked by my medical students to kind of create this. They like my style, they like what I'm doing. And I've asked them, how do you want this? So I can just demo it real quick if that's okay. Yeah, it's a great segue. I didn't put that guy there. Radiology is complicated. I mean, you know, I showed this to senior residents. I just asked them, can you identify the studies? Like, do you know what actually modalities those are or protocols, whatever it is? And it's, like I said, it's a skill set of utilization and navigation. What's the patient experience? What's the one best test? All of that stuff. And somehow, like I said, it's just been ignored by many medical schools across the board. And somehow even the online education industry didn't pick up on this. Now, I mean, I had a student, actually is a medical student at University of Miami. I only know him because I coached him in middle school football for a couple of years, him and his brother, and he just took step 2. And he called me, and he doesn't call me professor, he calls me coach. And he said, Coach, you won't believe there were 100 questions on radiology out of 300 on step 2. I said, that's not possible. He said, well, there were 25 questions with images. And then there were a whole bunch of questions where they described the findings without a picture. And then a whole bunch more that had a radiology concept in one of the choices. Maybe it was the right choice, maybe it was the wrong. What's the next best step? You know, send the patient home, go to the OR, CT with contrast. So he counted 100, he told me, out of the 300, which I couldn't believe. And yet no one's sort of teaching to it. So there is nothing. And that, believe me, before I went on this endeavor, I checked with every student and resident that I could. And they asked me to put something together. So this is in the works. It's actually out there. You know, the first 75 videos I've made. I hope to finish the entire course by the end of the year. It's look, it's billed as a step 2 kind of prep. There's stuff on step 1, there's stuff on step 3. But if you take this course, you're also going to know what you need to know to actually be a doctor, which is really what I'm most interested in. But since students are a little bit preoccupied with step 2, that's how they wanted me to parse this. And this is coming from the students telling me, we don't want long videos. So I'll break it up however you want. The product is called This Is Rad, and it's thisisradiology.com. And there are videos like this, which I'll take you through it in an organized way. And they're short. I mean, the average video is right now, I just checked on the first 75 is like 4 minutes and 45 seconds. So you're in and you're out. Someone told me if I made a 15-minute video, they're not watching it. I don't know how that student's going to do a 6-hour surgery, but they don't want to watch a 15-minute video. That's how it is. There's something called high yield that you all love to say. I don't know what, you know, you lost the high yield facts, so that's what I'm concentrating on. These are all my images, so you won't see them anywhere else, right? And some of these review books have really small images with no captions. I kind of went through the things you're using to see what's out there and to see what they think is fair game. But then I found my own pictures, and you could use a review book, and then when you get to a picture, find my video and then swipe through it. Everything is labeled, arrows, kind of the style that you just saw before. I mean, just trying to spell it out for you. They want buzzwords. I put in the buzzwords. Don't get hung up on buzzwords. I have 4th-year students that rotate with me. Most of the people on the left are 4th year, and they say to me, I spent 3 years learning buzzwords. And I know every buzzword and how it connects to a disease, but I don't know what the buzzword means, and I don't know anything about that disease. And now I'm a fourth year and I want to be a surgeon. I don't know anything about like so don't get hung up, but I'm putting them in there because they're on the boards, and I'll give you a better way to think about it. I'd rather you understand and remember something than memorize it. There's too much information here to kind of grope through it and hope that the mnemonics stick. So I'll just give you enough of background, of what the concept is so that you can understand why the imaging looks the way it does. That's my approach, but I threw the buzzwords in also. Does anybody here know what Anki is? So they told me they like flashcard style stuff. So I made my own with they're also written, there are quizzes that you can click on the actual questions, but this is without the audio. This is one of the videos where I'll show you a case and then a pause icon. Now you pause the video there and you think about it. And then when you think you know the answer, you hit play and I'll flip the Anki card, which is mine. And then I'll give you literally in these review sessions, 15 seconds on why that's the answer. And then rapid fire, we go to the next case. Because some people wanted only that. So there's that. And just to show you what it kind of looks like, this is one module, for example, under the GU, genitourinary tract. So you'll have short videos on one particular topic, getting to the imaging of what it is and why it looks that way, what you need for the boards. And as a clinician, I'm not making you radiologists for this. It's on the medical student level. And I'm trying to introduce you to I don't take anything for granted in terms of nomenclature and all that stuff. We're going to spell it all out and serve it up to you. And then at the end, like here's this is a short module. There's only 4 videos that you really need to know. And then there's the bare bones review where all 4 of those videos are then, I just take rapid fire cases and throw them at you and let you pause. So that's how that works. And then there's a quiz and then you move on. So give it a shot. You can screenshot, screenshot this. Mostly right now, I just want to get the feedback. I want to, sharpen this even more. The Nova students had it last spring, the first module, and I'm, very pleased. I'm very flattered and thrilled with the feedback. It's only me. It's very time consuming, but people have been asking me to do it for a long time. So I'm excited to get started, and it's more than started. I'm probably a third to a half done. And obviously it's not a complete thing here. So I'm giving you all the discount code if you want to give it a shot. But if you like it, give me the feedback. If you don't, tell me what you don't want about it or you don't like. I mean, that's how I learn what you want. I'm trying to serve it up for you. So I'm glad you asked. Thank you for that. I hope you give it a try. This is rad. It's the thing is, this is radiology, but the QR code will take you there. So thank you very much. I appreciate the time.